Assalamu alaikum and a very good morning from SOGP Organizing Committee for the SOGP Virtual Symposium. This is our second international speaker session. We have an August gathering of speakers and panelists today with us. Few housekeeping things to remember while we are in this webinar. We have to keep our audios and videos off. You can put the questions and answers in your chat box, which can be searched at your Zoom menu. Once the questions relevant to the talk have been put forward, they will be taken up by the moderator and panelists and put to the relevant speakers. For asking questions, if there is a pertinent question, you can also use the option of raising your hands. Your e-certificates will be sent after you submit your feedback form. I hope that all of you will enjoy the session today.
So the moderator for this session is Professor Halima Yasmin. She is head of Department of Obstetrics and Gynecology, Ward 8 at Jinnah Postgraduate Medical Center, Karachi. She's affiliated with National Medical Center, Boulevard Hospital, Shamsi Hospital, Atia Hospital, and Al Mamouna Clinic. She's the Secretary General of the Society of Obstetricians and Gynecologists. She received the Young Gynecologist Award at AOCOG and a FIGO Congress in Tokyo in 2007. She also received the FIGO Fellowship Award in Cape Town in 2009. She's an executive member of AMAN and an honorary founder member of MAP, which is Midwifery Association of Pakistan. And she's also an active member of National Committee for Maternal Health.
Thank you very much, Dr. Sadia Hassan. Let me introduce now my chairs for the session today. Dr. Sadia Hassan Pal is Chairperson Maternal and Fetal Health Committee of CEFOC. She's a consultant gynecologist at OMI Hospital, Medical Director of Concept Fertility Center, Karachi. She's ex-Vice President of the National Society. She is member editorial board of JPMA, which is a high impact journal of Pakistan. She is member of National Committee of Maternal and Neonatal Health and Association for Mothers and Newborns. She is also a faculty at the Society of Laparoscopic Surgeons of Pakistan. My next chair for the session is Professor Shama Monim. Professor Shama Monim is the pioneer of fetal medicine specialty in Pakistan. She is Professor of Obstetrics and Gynecology and a special interest in fetal medicine. She is currently working at South City Hospital and Jinnah Medical University. She has a diploma in fetal medicine from United Kingdom, along with a fellowship in fetal medicine from UK. She is an RCOG-RCR Advanced Scanning Certified Professional. The panel of experts today consists of Dr. Fozia Manu. She is head of OB-GYN department at Evercare Hospital, ex-head of the department at Fatma Memorial Medical College. She is member and fellow of the RCOG. She is visiting consultant at Hamid Latif Hospital, Lahore. She is a senior member of SOGP. She is a trainer and supervisor and examiner for CPSP, as well as Canadian College for Family Medicine. She conducts courses and workshops on research and also is an examiner for FCPS exams. She has numerous publications in recognized journals on her credit. The next panelist is Dr. Professor Abira Chaudhry. She is head of obstetrics and gynecology at Pak Emirates Military Hospital, Rawalpindi. She is director of postgraduate gynae training program at Armed Forces Postgraduate Medical Institute. She is convener of examiner at CPSP. She is paper setter of undergraduate and postgraduate medical colleges. Dr. Abira is also awarded the Tamgha Imtiaz by military. She has 31 years of experience in armed forces. Next panelist is Professor Rehana Rahim. She is an MRCOG FRCOG. She is senior member of SOGP. Currently, she is secretary of academic board of SOGP. She works in the capacity of head of the department at MTI Lady Reading Hospital, Peshawar. After introduction of the panelists, Now, let me introduce the first speaker for the session today. Our first speaker for the session is Professor Mansoor Raza Mirza from Copenhagen University Hospital. He is Medical Director of Nordic Society of Gynecological Oncology. He is Chair-elect, European Network of Gynecological Trial Groups. He is Executive Group at Gynecological Cancer Intergroup. He is the Faculty of European Society of Medical Oncology and International Gynecological Cancer Society. He is a faculty of European Society of Gynecological Oncology as well. He is currently working as the core faculty of European School of Oncology, and as I told earlier, working as chief medical oncologist at Copenhagen University Hospital. He is going to talk about the updates in endometrial cancer with us today. Professor Mirza for his talk.
Can you see my slides? I'm not sure if you can hear me.
We can see and hear.
Oh, great, thanks. And thanks again to everyone for inviting me to such a prestigious meeting. And thanks, Dr. Sadia Pal, for your kind invitation. I'm clinical oncologist in Copenhagen University Hospital, and I was asked to talk about management of endometrial cancer, the new developments. As I'm clinical oncologist, I will just touch a little bit on surgery. Mostly my talk is on non-surgical treatment. These are my disclosures. I think the best thing has happened this year is the new FIGO classification book is out, and I'm sure we will hear about it later. The great thing is that the molecular classification is added in endometrial cancer, which was extremely important. And we have been working to update our guidelines in European Society of Gynecological Oncology, Radiation Therapy, and Pathologists, the ESP. So we have this is not published yet. It is about to be published, but we have finalized our guidelines of the management of patients with endometrial carcinoma, and where we have made the risk group according to if molecular classification is not available and if molecular classification is known. So we have divided patients into low risk, intermediate risk, high intermediate risk, high risk, and advanced metastatic disease. I think the most important thing regarding the risk groups would be, we discussed a lot that we did not want it to impose molecular classification, but if the pathologist can perform P53, and if it is possible to do the poly mutation test as well as the MMR or MSI test, we would be very well equipped with the molecular classification and decide how to treat the patient, if patient is in risk or not. Just follow. I think this will be published. Our guidelines will be published in about a couple of months in our international journal. So I've taken a couple of snapshots from that guidelines to give you an idea how we have, it's both guidelines and consensus, how we have ended up. So these are just a couple of snapshots. It's a very detailed guideline. So if, for example, surgical management of apparent stage 1 disease, standard surgery is total hysterectomy with bilateral salpingo-oophorectomy without vaginal cuff resection. Then you have degree of level of evidence and degree of recommendation in all these statements. Staging infracolic lumpectomy should be performed in clinical stage 1, serous endometrial carcinoma, carcinosarcoma, and undifferentiated carcinoma. We discussed and agreed that it can be omitted in clear cell and endometrioid carcinomas in stage 1 disease. And surgical restaging can be considered in previously incompletely staged patients with high intermediate risk, high risk disease, if outcome might have an implication on adjuvant treatment strategy. For the lymph node staging, this is a very comprehensive chapter and guidelines. So sentinel node biopsy can be considered for staging purposes in patients with low risk, intermediate risk disease. It can be omitted in cases without myometrial invasion. Systemic lymphadenectomy is not recommended in this group. Then surgical lymph node staging should be performed in patients with high intermediate risk, high risk disease. When you're doing systemic lymphadenectomy, pelvic and para-aortic infrarenal lymphadenectomy is suggested. Presence of both macro and micrometastasis is regarded as a metastatic involvement, and if pelvic lymph node involvement is found intraoperatively, further systemic pelvic lymphadenectomy should be omitted. However, debulking of enlarged lymph nodes and para-aortic staging can be considered. So please keep an eye. We will be publishing both these ESGO, ESTRO, and ESP guidelines, and at the same time in Annals of Oncology, we have just revised also guidelines for ESMO, for European Society of Medical Oncology, and those will be published. So these will be some parallel guidelines coming in within a few months from now on. Now I will move down to the non-surgical treatment of endometrial cancer and start with radiation therapy. So what is the role of and what is the evidence, if there is a level 1 evidence of adjuvant radiotherapy in endometrial cancer? Yes, there is. There are multiple trials performed, and all these trials ended up showing us that overall survival is not affected if these are the primary endpoints of these trials, that you do not improve overall survival with radiation therapy, but you definitely improve local regional control. The cost of local regional control is high because the long-term follow-up may show that this is quite a added toxicity and deteriorated quality of life of these patients. And maybe there is some hints that the patients may be doing even worse who have received radiation therapy regarding the overall survival. One of the oldest trial was Jeanne trial, the Oslo trial, and that was revisited. And this is the 40 years of follow-up of that trial, radiation therapy or no radiation therapy, external beam radiation therapy. And you can see that patients who were under 60 years of age at the time of the treatment, who could had 40 years of follow-up, the patient the radiation therapy is not improving survival. On the contrary, and the rate of secondary malignancies is almost doubled. These are some things you have to keep in mind when you are trying to plan treatment for the patients. How aggressive you want to be, what are the consequences we may see in these patients. So from now, I will go down to systemic therapy and start with the adjuvant chemotherapy and adjuvant endocrine therapy. And after that, we will take the systemic therapy for advanced disease. For the adjuvant chemotherapy for early stage disease, we have ample of studies done which have tried to show adding chemotherapy on radiation therapy, the GOG-34, the Finnish trial, the GOG-184 trial. Well, GOG-184 trial was chemotherapy plus chemotherapy, different regimens. All these trials were negative. They did not show any improvement in PFS, in progression-free or overall survival by adding chemotherapy to radiation therapy. The last trials, the NSGO, our own trial, 9501, showed there was benefit in progression-free survival, but trial was not powered to see the overall survival. However, the hazard ratio was 0.69, which is very impressive. The confirmatory trial, one can say, the PORIC-3 by the Dutch group, was performed in the same setting. The only difference was here, radiation therapy was given concomitant, the chemotherapy was given both concomitant and maintenance. In our trial, the radiation therapy was separate to chemotherapy. And that trial could not show any improvement in PFS or OS in these patients. And one can discuss, there was some subgroup analysis in the patients who had more advanced disease, stage 3 disease, but that subgroup analysis has a very small number of patients that gives a hypothesis, but we can't move any further to that. And on top of that, the problem with the last two trials, our own NSGO trial and the POTIC, was that we did not perform systemic lymphadenectomy. And as you can see, the risk of lymph node involvement is quite high already in early stage disease. If you look at the grade 3, more than 50% myometrial involvement, almost 1/3 of these patients may have metastatic lymph nodes. And if you don't do lymphadenectomy, you would stage them as stage 1 and not stage 3C. So these are the problems with these trials. When we come to adjuvant chemotherapy, role of adjuvant chemotherapy, the trials, I think the first trial, which is everybody would like to show, but that's in stage 3 and 4, was the whole abdominal radiation therapy, which was standard of care in US at that time, versus 8 cycles of adriamycin and cisplatin, which showed significant improvement in survival and progression-free survival by giving chemotherapy compared against a whole abdominal radiation therapy. Then you have Italian trial and the Japanese trial. We could not show improvement in survival or PFS by giving chemotherapy against adjuvant radiation therapy. These trials were mostly criticized for a number of courses were quite low, and the patients diluted, especially in the Japanese trial. Half of the population was in very high, very good prognosis population. Probably that could be one of the reasons. And then GOG did the trial, which was presented recently, a few years ago, at SGO. It's not published yet, which showed that there was no difference in PFS or OS if you do either a radiation therapy, which was standard of care arm, versus 3 cycles of carboplatin paclitaxel. Again, this trial was criticized because both this trial and the POTIC 3 had half of the population which were not high-risk patients. And if you look at their 5-year survival, it's so good that it's difficult to see that you will improve that any further. So these trials were diluted by very good prognosis patients. We were unable to see the results in the high-risk population, which is this one. And the trial which has not shown results yet is the EN2 trial, which is Danish group trial. And we have randomized these high-risk patients into either chemotherapy or observation. In both cases, brachytherapy is allowed. And as you can see, it's a global trial. All European groups, and MD Anderson is part of this trial. So overall survival is primary endpoint. We would probably not have results available until 2023. I think this trial is important because in the state, continuous to the one I have shown is the early stage disease, stage 1 and 2. And here you have stage 3 disease, the GOG 258 trial, where patients who received after surgery chemotherapy, the radiation therapy was added to chemotherapy. It added to toxicity, but did not add to overall survival. Local control was better. And that was another proof that probably we are not improving survival by adding radiation therapy to chemotherapy. So the standard of care of chemotherapy now is 6 cycles of carboplatin paclitaxel. What about hormonal therapy? Now we are talking about endocrine therapy, not as in the system in the metastatic disease, but as adjuvant. And there is enough data available that adjuvant hormonal therapy has not proven of any benefit. If we go to the systemic therapy, now it's the stage, either primary stage 4 disease or first relapse, and endocrine therapy, we have again quite a few clinical trials available comparing, as I said, Rental trial, but the first one, and then single agent chemotherapy versus doublet doublet versus doublet when paclitaxel was introduced, and the very important trial, doublet versus triplet. The most active agents were doxorubicin and cisplatin. They were compared to doxorubicin, cisplatin, and paclitaxel. That trial showed significant benefit of triplet, but it was too toxic and it was not accepted by community to be a standard of care. And that's why the GOG 209 trial, which is just published this 2 weeks ago, after all, which has compared the triplet to the modern regimen of carboplatin paclitaxel. It was a non-inferiority trial, and it showed that carboplatin taxol was equally effective to the triplet, but much less toxic. So again, the chemotherapy, standard chemotherapy, has become carboplatin paclitaxel. What happens when patient has progressed after carboplatin paclitaxel? Actually, we don't have anything. All what we do is we try to treat them as it is in ovarian cancer, but the responses are quite pathetic, and we have not reached anything there with conventional chemotherapy, and hormonal therapy has not shown any wow benefit in these patients, even in the endocrine, the hormone receptor positive disease. As you can see, the trials are, there are not any much randomized trials, so these are level of evidence which is quite low in all these statements we have made in the ESGO ESMO guidelines in 2016. That is unchanged. So if you look at the results of ESMO ESGO ESTRO guidelines, it was very clear that in advanced and recurrent disease, standard of care first-line chemotherapy is 6 cycles of paclitaxel carboplatin, but after that, there is no standard of care for second-line chemotherapy and targeted therapy. There is no approved targeted therapy available, and we need biomarker-driven trials in this population. And that brings me to the next chapter, which is all the targeted therapies. We have, as I said, there are no regimens which are approved, and I will go through what is happening and what results are there, so it will give you an idea, and at the end I will give you a short update on immune therapy. So I think the best thing has happened is the TCGA, the Cancer Genome Atlas paper came out, and we started to work on looking at not only as histological classification, but also the TCGA subtype, the mutation load, and compare it to the histological classification. We started looking at the P53 mutational status, PI3K, and all this has given us a possibility to use the new agents in these patients. First of all, I will go to the VEGF, the vascular anti-angiogenic therapy, and I will show you 2 trials. One of these trials is a small METO and 2 trial, the Italian trial, where patients who were stage 4 disease or first relapse, these patients received chemotherapy, carboplatin paclitaxel plus minus bevacizumab, 100-patient trial showing there was a benefit of PFS. They have just published the data on OS. There was no benefit in OS. It's a small trial. It was not powered to show the OS data. And then Jeanne presented in the same ASCO meeting in 2015 a trial where there is no standard of care arm. There were 3 experimental arms, and then it was compared to historic control of carboplatin paclitaxel, and it shows that the triplet with bevacizumab is doing better. So this is the evidence what we have on anti-angiogenic therapy. We don't have any other evidence. There is 1 trial result pending. We will see that next year is the study with the tyrosine kinase inhibitor against VEGF, the nintedanib trial, which is placebo-controlled carboplatin in the same population for either advanced stage, primary advanced stage disease or first relapse. And it's a small trial of 150 patients, and we would know if there is any role of tyrosine kinase inhibitors against VEGF in these patients. So if we move now to more specific mTOR and PI3K inhibitors, we have quite a few small trials available, non-randomized trials available, a couple of phase 2 randomized trials, all showing some moderate activity. The problem has been that we have taken mTOR inhibitor to start with, which are probably the toxic side, PI3K as well. They are quite toxic, and I don't know how we are going to move with them. The couple of trials which have been presented by Amitoza of mTOR inhibitor against comparator showing progression-free survival benefit. The trial was not powered for OS, and it did not show any OS benefit at all. Brian Slomovich presented data on another mTOR inhibitor given together with letrozole against standard of care, and again showed that there was a benefit in progression-free survival, and probably, again, these are the things we have to move further to see if we, in phase 3 setting, we can see any benefit in subset of patients. At ESMO this year, last month, we presented the data on the first global randomized CDK4/6 inhibitor trial. It was a placebo-controlled trial in endocrine receptor positive disease, metastatic disease. Patients were randomized either to letrozole plus placebo or letrozole plus palbociclib, which is a CDK4/6 inhibitor. And progression-free survival was improved from median of 3 months to 8.3 months. And the secondary endpoint disease control rate was also almost doubled. But now that means that we need to do a phase 3 trial to see if this holds on, and we can, at least for the estrogen receptor positive patients, introduce CDK4/6 inhibitors together with endocrine therapy. Another very interesting pathway is being selected. This is first-in-class drug called selinexor. It's an oral selective inhibitor of nuclear export. What happens is that all the time in our cells, the good genes like our retinoblastoma gene or P53 or IKB, these genes go out of nucleus to cytoplasm and come back. And cancer cells won't let them come back, they block it. Here, this drug exploitin stop the transport of these good genes from nucleus to cytoplasm. So they stay in the nucleus and do the programmed cell death. And phase 3 trial is ongoing, which is led by our Belgian colleagues in Europe, and GOG US and Canada is also participating. So this is the first trial. It's a pure maintenance trial after carboplatin paclitaxel chemotherapy. Probably we will see results by 21 or 22 and see if there is improvement in outcome of our patients. At the end, I would like to go to immune checkpoint inhibitors. I think this is the area in gynecologic oncology, endometrial cancer, where checkpoint inhibitors have completely revolutionized our thoughts. And the reason again is that the Cancer Genome Atlas data, which has given us a new way to look at our patients, not histologically, but very highly ultra mutated, the polymutated or MSI hypermutated patients, or MMR deficient, the mismatch repair deficient patients. These are the patients which will be highly responsive to immune therapeutic agents, checkpoint inhibitors. And then you have so-called cold tumors, copy number low and copy number high, and there probably you would need some other strategies to combine immune therapy with other agents. If you look at the hot tumors, the poly and ultra mutated, these are the patients who are deficient, MMR deficient. The one on the left side, this is the largest trial in these patients. It's a non-randomized trial, the Garnet study. The updated data was presented last month, showing that 45% of the patients will respond to this treatment. Remember, these responses in immune therapy are long-term responses. These patients really When you see responses of immune therapy, it can be a very long-term responses. The tail is quite thick and quite prolonged, and that is impressive. So probably we are going to see these very positive data available. On the other hand, if you look at the cold tumors, Vicky Macker presented the data combining a tyrosine kinase inhibitor lenvatinib to pembrolizumab and showed a response rates of 39%, and that has brought this combination to FDA with the new way of approvals, where you get approval both for US, Australia, and Canada at the same time. And that the combination is approved, and it will be approved in Europe by EMA as well by end of the year. So we have already the data on non-randomized trials, and that has bring us to multiple trials, the randomized trials, phase 3 trials running at the moment. None of these have finished recruitment. And these are asking basically 3 major questions. In the locally advanced and in first relapse disease, if we can add PD1 or PD-L1 checkpoint inhibitor to chemotherapy and improve the survival, that's one. That's the 3 trials. This the Ruby trial, a 10 trial, and an AG trial. And then there is a question if we can completely remove chemotherapy, and this trial is comparing chemotherapy versus pembrolizumab and lenvatinib, the AGO Austria trial. And the last trial is very interesting, run by GOG, where you are giving concomitant PD-L1 on top of chemotherapy, and at end of chemotherapy adding a PARP inhibitor as maintenance. So you can see that these trials with about 4,000 patients altogether, there's one more trial with pembrolizumab in early stage high-risk group. These trials will be answering the question if immune therapy is going to be standard of care for our patients. And remember, if you have responses on immune therapy, they are durable responses. So in conclusion, I would say surgery is the main treatment modality for early stage endometrial cancer. Radiotherapy can improve local control at the cost of excessive toxicity. However, radiotherapy does not improve survival. Chemotherapy is beneficial in advanced and metastatic endometrial cancer. We still have to see the role of chemotherapy in early stage disease. Novel agents are being widely tested in endometrial cancer. Immune therapy seems to have definite place in the management of endometrial cancer, both as single agent or in combination with other targeted agents. But we have to improve our management. Endometrial cancer management has to be improved. Thank you, and that's it.
Thank you. Thank you very much, Dr. Mansoor Raza Mirza, for bringing in the concept of angiogenic inhibitors and immune modulators. Let me now introduce the second speaker for the session today, Dr. Lubna Pal. Dr. Lubna Pal works at Yale University. Dr. Lubna is a very senior member of SOGP as well, who is currently working abroad, and she is a great speaker. She is currently working as a vice chair of education at Yale University with special interest in reproductive endocrinology, polycystic ovarian syndrome, and subfertility endocrinology treatment. Dr. Lubna Pal is going to talk about recurrent pregnancy losses.
Thank you so much, Halima. Assalamu alaikum. My video is switched off from your end.
We can hear you and we can see you.
Oh, you can see me? Okay, because I'm getting it. Thank you so much. So, assalamu alaikum ji, what a pleasure to join you all. Thank you to SOGP for this privilege. I was asked to speak on recurrent pregnancy loss. I wish I could start by saying I have as much of evidence-based data as our past speaker, Dr. Mirza. That was an excellent talk. I don't have any disclosures. I'm getting these pop-ups at my end. And I'm having trouble advancing slides, guys. Okay, so I'm hoping over the next 20 minutes or so, I'm going to go over sort of the paradigm shift in terminology in recurrent pregnancy loss, put into perspective prognosis for patients with RPL, touch upon the pathophysiology. That's an area where we are learning a little bit more. We have made some progress in the last decade, but there is tremendous room to understand the underpinnings of RPL. And I'm hoping at the end of this talk that we are able to collectively get inspired and ignited in terms of trying to understand what are the pathophysiological mechanisms relevant to the community back home in Pakistan? Because the data that exists, global data, primarily dominated by data contributed from the Western world, we have such little understanding of pathophysiology of RPL in our part of the world. And then we'll talk about individualized workup and focus on evidence-based management. My apologies if my dog is here and it's early in the morning, so he is seeing something outside. So nothing to disclose. So I'm assuming everybody is familiar with the changing paradigm. When I was a trainee, I still recall we needed at least 3 pregnancy losses, 3 successive pregnancy losses in those days under 24 weeks of gestation before we could call somebody as having recurrent miscarriage. In those days, the term used to be habitual abortion, which really is obsolete. It's completely gone now. So the most recent nomenclature we're working with is sort of shaped by the ESHRE 2017 guidelines that were published in 2018. ASRM, American Society for Reproductive Medicine, considered the existing guidelines in 2019 and sort of stayed with the ESHRE paradigm. I would want to bring to your attention that pregnancy now under the ESHRE guidelines, a positive pregnancy test, whether urine-based or serum-based, is enough to qualify as a pregnancy. Previously, we focused on a pregnancy loss had to be a clinical loss, ultrasound evidence or products of conception seen on histopathology before we could quantify and qualify it as contributing to RPL definition. But now biochemical pregnancies and pregnancies of unknown location are included in this terminology. Weeks of gestation up to 24 weeks. Having said that, there is a distinction made between recurrent pregnancy loss, that is early, less than 10 weeks, because the pathophysiology is a little bit different, versus more advanced pregnancy loss, which is between 10 to 24 weeks. We're still staying with 2 losses are good enough or bad enough to quantify and qualify for the diagnosis of RPL. And those 2 losses don't need to be consecutive. So you could have a successful pregnancy followed by 2 losses. You could have a loss, a successful pregnancy and another loss. So consecutive or non-consecutive losses should be considered in trying to understand which patient needs evaluation for this diagnosis of recurrent pregnancy loss, recognizing that the psychological burden, the emotional burden, the societal burden, and the financial burden of evaluation really is shared by the community. So we want to be sensitive and preemptive and start our evaluation much sooner than we used to in the past. Why did we sort of, the net that was thrown for this diagnosis, why has it included biochemical losses, is the realization that any loss, be it biochemical, be it clinical, has some prognostic implication for a subsequent pregnancy. And these are all observational study-based understandings. No RCTs are here to guide us, but observational data seem to suggest that every loss, be it biochemical, be it clinical, be it pregnancy of unknown location, but much less so with the PULs, reduces the likelihood of successful live birth in a subsequent pregnancy by anything from 9 to 11%. So based on this observational body of data, was the consideration that biochemical losses should also be included in the terminology of recurrent pregnancy loss. So how common is this entity? So I'm talking about an uncommon scenario. RPL affects about 1 to 2% of couples getting pregnant experience enough losses to meet the criteria for recurrent pregnancy loss. Now, recognizing that this prevalence is based on older data where clinical losses were defining this terminology. So I do believe in the next decade, these numbers will change now that we have much more stringent diagnosis of pregnancy very early on in the process of conception. With assisted reproductive technologies, patients are being monitored so much closer that even a positive pregnancy test with a serum HCG level of 10 is now considered a pregnancy. So I think these numbers will change, recognizing that there is tremendous redundancy in human reproduction. So as much as 30% of conceptions are destined to miscarry. So of those high magnitudes of losses, only a fraction make it to meet the criteria of RPL. And then older terminology of needing up to 3 consecutive pregnancy losses, it's 0.4 to 1%. But like I said, with newer terminology, these numbers will change. And again, underscoring for you the concept that RPL should be sort of in our mind when we are considering differential diagnoses. We should think about, am I dealing with primary recurrent pregnancy loss, which means no prior pregnancy success, versus secondary RPL. So primary still dominate the overall prevalence of this problem. This is one of the etiological underpinnings to RPL. There's large number of studies that sort of give the same splatter of the pie chart that I'm showing you. Contributors includes a panel on the right, sort of connects the various colors of the pie, about anything from 16 to 20% in different studies. Etiology may be anatomical, and anatomical relates to the uterine anatomy. So structure of the uterus, primarily septate uterus, Mullerian anomalies, but we in our part of the world are seeing more and more intrauterine syncytiae consequent to Ds and Cs mostly, as a mechanism for biochemical losses, very early losses. Endocrine underpinnings, thyroid dysfunction dominates this piece of the pie, but there are extreme endocrinopathies, including poorly controlled diabetes, is contributing to this piece of the pie. 3% of the losses, when they are karyotyped stringently, are attributed to either one of the parents having a structural anomaly of their chromosomal profile. Having said that, while only 3% of the losses relate to parental transmission, there's a much higher proportion of losses that are attributed to aneuploidy, and that primarily results because of effect of aging or contribution of aging to aneuploid pregnancy loss. So this particular study, which was data started in 1996 and then recapitulated, reaffirmed in 2014 by Mary Stevenson, who is a big name in the field of recurrent pregnancy loss. Their data and many other groups are really unraveling potential role of chronic endometritis as a mechanism for pregnancy loss. Again, bulk of data are observational. These are associative studies. Onus is on us to establish causative relationship. But what we do know is treating RPL patients with chronic endometritis, their subsequent live birth rate does increase. So there is some extrapolation of cause and effect relationship to this observation. So in the last decade, chronic endometritis really has surfaced as a plausible player. The orange piece of the pie, autoimmune mechanisms as a contributor to RPL, probably dominating in this is the antiphospholipid antibody syndrome, which is again in the spectrum of autoimmunity. It is a dominant disorder affecting women way more than men in the population. And the association of APLS with pregnancy loss relates to diagnosis of APLS in the mom and not the father thus far. Thyroid dysfunction, particularly Hashimoto's thyroiditis, has been recognized as a contributor to sporadic losses, but its relevance for recurrent pregnancy losses is thus far unclear. Having said that, now that we are going to include biochemical losses, and we do know from the ART literature that Hashimoto's thyroiditis has been linked with a higher incidence of implantation failures and a higher incidence of a sort of higher probability of reduced ART success in a subgroup of this population. I do believe this is something we need to be looking out for, because these proportions may shift. And then the biggest category, which really is the shrinking category, is that of idiopathic or unexplained. So more and more now, we are trying to understand, with the tools that are becoming available to us, much more refined comb to see through the genetics, the genome of the products of conception. I anticipate, and we anticipate, that this is a category that will shrink. There's a lot of effort going on using whole exome sequencing to really try and comb through the genome of the products to identify. It may not just be the genome, it may be the epigenome that may translate into propensity for loss. So I think in the next decade, there will be a breakthrough in our understanding, and this particular piece of the pie we will be carving a few more pieces in this pie. So quickly moving on to what we do know as reliable underpinnings to predisposition to RPL. One is anatomical factors, and as I mentioned, Mullerian anomalies, developmental anomalies are a recognized contributor to predisposition to recurrent pregnancy loss. Almost 2 to 40% of RPL cases, when you evaluate them, may have one of the spectrum that is shown on the right side of Mullerian anomalies. It could be as subtle as an arcuate uterus. It could be as robust and profound as any of the anomalies that I'm showing on the right. So the uterus didelphus, the bicornus bicollis, they have really been tied more with preterm birth rather than RPL. It's the septum, it's the septate uterus that has been linked with recurrent pregnancy loss predisposition, length of the septum, and now with the 3D ultrasound as well as MRI imaging, some understanding that maybe not just the length of the septum, but maybe the width of the septum may also be relevant. Accruing data, when I was a student, arcuate uterus was really defined as a variant of normal. Observational data seem to suggest that arcuate uterus may not be entirely benign, because preterm birth is a little bit higher. Second trimester losses are a little bit higher in patients with the arcuate anomaly. As I had mentioned earlier, in our part of the world, intrauterine syncytiae are increasingly becoming apparent in patients with biochemical losses. This is a patient I operated upon on Friday. Panel on the left is a sonohistogram that really raises concerns. This patient had 2 first trimester losses, both managed with a DNC, and now is interested in getting pregnant and has developed secondary infertility. Sonohistogram raises suspicion for intrauterine focal pathology, and a panel on the right, hysteroscopy, showed severe Asherman syndrome. And you can almost see this hole is leading to the fundal area. The rest of it is all obscured. We were able to take down about 90% of the adhesions. She's going to require 1 more procedure. And I do anticipate her uterine cavity will be normalized, but she is at risk for placentation problems, placenta accreta, increta, percreta. So intrauterine syncytia, there may be an iatrogenic component to this category. So we as OBs and gynecologists should really be vigilant about which are the patients where surgery is really indicated for evacuation of products versus which are the patients, if we can safely manage medical losses medically, we may be helping the patients and reducing the risk for intrauterine iatrogenic pathology. Moving on to parental chromosomal structural anomalies, this is only 3% of the piece of the pie was contributing to RPL, and this is parental-driven contribution to creation of unbalanced products of conception. So 3 to 5% of patients with RPL, when the parents are evaluated karyotypically, they're carrying inversions or translocations. The green top guidelines from RCOG, it's 9 years old already. Excellent review of this particular topic. Recognize then that when either one of the parents is carrying a structural anomaly. They themselves are fine, but their gametes are contributing to an unbalanced conceptus. 1/3 of their losses would be genetically abnormal, but they have about 70 to 80% chance of conceiving a karyotypically normal conceptus as well. So reassurance has a huge role to play in managing patients who have one of the parents has a translocation. Provided time is on their side, provided they're not emotionally devastated, there is data seen to support expectant management has a role in this, in managing of this patient population, provided they can sustain the angst, because the incidence of pregnancy loss is much higher in this population. So sort of flipping the coin to now look at what proportion of conceptuses are genetically abnormal in patients who are experiencing RPL compared to patients who are experiencing sporadic losses. So this is, again, this is a population-based study where 285 patients with documented RPL had their products of conception tested cytogenetically, compared to a population data as well as an institutional data of thousands of losses where cytogenetics were evaluated. And the bottom line is, and the horizontal axis here is identifying the age of the mom at the time of conception, and the vertical axis is presenting percentage of cytogenetic abnormalities. Blue bars RPL, and orange bars are sporadic losses. And what you can see, that genetic abnormality in sporadic losses exceeds the prevalence of abnormalities in RPL losses. So karyotypic abnormality is not a dominant contributor to recurrent pregnancy loss. Having said that, you can also see the bars are rising as you go from a younger age group to an older age group. So aging itself is a contributor to cytogenetic abnormalities. So if a 40-year-old is having RPL, probability that she may have karyotypic abnormality of products just by virtue of chance related to her age is high. So place that concept in the context. So RPL patients do not have a higher predisposition to aneuploid losses in comparison to sporadic losses. I think that's the message going. Endocrine factors, I had mentioned already. Multiple things have been looked at, have been tied into sporadic losses, but relationship to RPL, really thyroid disorders have some soft relationship, and it's Hashimoto's thyroiditis that we need to be on the lookout for. As I had mentioned, now that we are including biochemical losses, these paradigms may shift, but as of now, our understanding is optimize general health, optimize endocrine milieu in patients who are experiencing RPL. In terms of the immunological conditions and their relationship to recurrent pregnancy loss, the prototype really is the antiphospholipid antibody syndrome. APL antibodies are identifiable in up to 15% of patients with RPL versus less than 2% in the low-risk population of women. And the mechanism, multiple mechanisms that have been identified, including direct effects of the antibodies at the level of trophoblastic biology, as well as activation of the complement cascade, inflammation, thrombosis, underscore the later the loss is, the more likelihood that there may be an immune underpinning. Also likelihood that there may be a thrombotic tendency. So antiphospholipid antibody syndrome has been linked with early losses as well as late losses, but much more so late losses. So 6 weeks loss, 7 weeks loss, unlikely to be APLS compared to a 9, 10, 11, 12 weeks loss or plus. I've already talked about Hashimoto's. Its relevance may become clearer in the context of biochemical losses. Switching gears to thrombophilias, so predisposition to clot, abnormal clotting, recognizing placentation is dependent on neovascularization. So blood vessels are being created. There is low pressure flow in the maternal villi, in the maternal lacunae. So when slowing of flow happens and there is a predisposition to clotting, thrombosis can happen. Factor V Leiden has been linked with early losses, much more so with late losses. Odds ratio is almost 8-fold. Prothrombin G mutation, APC resistance, and protein S. These are the things that have been linked with RPL. so these are forest plots for some systematic reviews, and the red boxes really define relationship with before 13 weeks loss, as well as for factor V Leiden, as well as prothrombin G mutations. But it's not just for before 13 weeks loss. These thrombophilias have been linked with losses at all stages, and that's what these circles are representing. So large body of data support the relevance of thrombophilias as an underpinning to RPL in the appropriate clinical scenario. So in a patient who is asymptomatic, no family history, who's having very early losses, maybe screening for thrombophilia is not the first line of management approach or evaluation approach. But if you are having later losses and you're looking at the placental pathology or trophoblastic pathology, and thrombosis is evident in histopathology, think about thrombophilias as a mechanism. And recognize also that not all forms of thrombophilia lead to RPL. So panel on the right are the thrombophilias that have been linked with RPL, with, beg your pardon, whereas panel on the left, larger chunk of thrombophilias, while they do exist, they've not been substantiated to be linked with recurrent pregnancy loss. And as far as the ESHRAE's 2017 guidelines are concerned, the suggestion is not to screen for hereditary thrombophilias unless in the context of research or when there are only in the event when there are additional risk factors. Recognized family history should be included in risk factor evaluation. Switching on to lifestyle and recurrent pregnancy loss, plenty of robust observational data linking tobacco exposures, environmental exposures, alcohol, extremes of body mass index, and even caffeine intake with pregnancy loss. Now, I have to say, I am completely ignorant of I left Pakistan, gosh, almost 25 years ago, in terms of epidemiology, in terms of environment and shifts in environmental exposures in our population. My sense is tobacco use is still highly prevalent, and it's even secondhand tobacco exposure has been linked to predisposition for pregnancy loss. So these are areas for examination in our part of the world to try and understand what are the environmental underpinnings. Alcohol use, again, alcohol, in our part of the world, there is indigent, local production of beverages, which are completely unstandardized. What goes on in them? What toxicities do they confer for the male as well as for the female? So these are really things where data are needed and regrouping is needed, and maybe SOGP can create some national efforts for data collection for us to understand the habits that may be related to predisposition to pregnancy loss. In the last decade, a realization really has surfaced and is burgeoning now that pregnancy is a team sport. Pregnancy loss could have contributions from male as well as female. In our part of the world, but also in this part of the world, unfortunately, pregnancy loss is a burden disproportionately shouldered by women, but it really is a partner's contribution is there as well. So multiple mechanisms have been put forth where male could be contributing to the predisposition to pregnancy loss, including structural chromosomal anomalies, numerical chromosomal anomalies, and more recently, sperm DNA fragmentation, which has tremendous spectrum of underpinnings, including environmental exposures, including genetic predisposition, including occupational exposures. Stress has also been shown to be potentially relevant for DNA fragmentation. And the panel on the right relates advancing paternal age. So these are meta-analyses, a systematic review of studies that have really shown that advancing age of the father is also relevant to as an independent predictor of recurrent pregnancy loss and sporadic pregnancy loss. Advancing paternal age has also been sort of strongly associated with risk for autism. So these are, I think, we as a community really need to understand, and one would assume, again, I'm completely assuming here, that the age of the father in our part of the world may be pretty relevant to what's going on at the level of the progeny, given that older men continue to attempt to procreate with more than one partner. So this is an area of exploration at our end. So evaluation of pregnancy loss, and I've already touched upon the mechanisms. So one needs to pause, reflect, what am I dealing with? And that has to be based on thorough evaluation of the patient's history, including the family history, evaluation of her losses. How early are the losses? Do I have data in terms of histology? What am I dealing with? Immunological evaluations, really APLS is what we are focusing on. Anatomical evaluation is the intrauterine anatomy that we focus on, hysteroscopy, sonohistogram, MRI. Endometrial pathology, ruling out chronic endometritis, which is now we understand seems to have a relevance. Endocrine evaluation, we don't have to throw a huge net. We need to think about being cost effective. Thyroid assessment, glycemic profile in the appropriate clinical setting. We should focus on getting a detailed history on lifestyle. Genetics, we're talking about genetics of the products, and we're talking about genetics of the parents contributing to those products. So those are the two concepts that I'll touch upon a little bit more. Thrombophilia screening, we don't have to do that unless we are dealing with late losses or a woman, or histological evidence of clots, sort of thrombosis of vessels in the villi. Sperm DNA fragmentation in our part of the world, there are evaluations going on right now. Recommendations are only in the research setting. Think about that possibility. So this is a very reassuring slide. This is old data, but it has spanned out in multiple observational studies where probability of success relating to the number of miscarriages. So a 40-year-old who has had 5 miscarriages has about 50% chance of having a live birth if that 40-year-old gets pregnant again. I mean, that's a profoundly reassuring number. 30-year-old has about a 70% chance or more of achieving a live birth even after 5 losses. So reassurance has a huge therapeutic role in management of patients with recurrent pregnancy loss. One thing to underscore, when a loss is because of aneuploidy, possibility of a second pregnancy being progressing to term is much higher than when a loss is euploid. So this really highlights the importance of understanding what is the kind of loss that I have had. So in our part of the world, first loss happens, so a second loss happens, we aim to send products of conception for karyotyping to try and understand, should I do a blanket assessment of this patient by doing such expensive studies, or should I really just karyotype the products? And if they're abnormal, I don't need to go on a wild goose chase in terms of doing all this extensive screening on the patient. I would reassure the couple that this is aneuploid. But a euploid miscarriage, we've got to think about other probabilities that I have talked about. So as a woman ages, her probability of aneuploid losses increases. But as in terms of number of losses any woman sustains, if she has had aneuploid losses, her chance of a subsequent normal pregnancy progressing to live birth are much higher than if she loses a genetically normal pregnancy. So managing the RPL, really a quick splatter, aspirin and heparin, gold standard of managing antiphospholipid antibody syndrome. You start roundabout documentation of a viable pregnancy. Patients who have been started even after an embryo transfer in an IVF, that is completely okay. So whether you wait till a fetal heartbeat or whether you start with a positive pregnancy test, it doesn't matter. Therapeutic efficacy is well described. You can reduce the incidence of loss by about 50% with this therapy. In terms of anatomical abnormalities, you correct the anatomy if possible. In our part of the world, gestational surrogacy is being utilized for managing RPL in the setting of gross distortions of uterine anatomy. Normalize the thyroid, normalize glycemia. Progesterone really has surfaced again in the last probably 2 to 3 years. More and more data coming out about therapeutic efficacy of progesterone supplementation, and it's really natural progesterone, which has been, most of the studies are supporting that. Micronized progesterone, starting in the luteal phase of the cycle. So don't wait till the positive pregnancy test before starting progesterone, start in the luteal phase of the cycle to reduce the likelihood of loss, sporadic loss, as well as recurrent pregnancy loss. Tender loving care has multiple studies have shown importance and therapeutic efficacy of just support. So I already showed you such great likelihood of subsequent pregnancy progressing to term to live birth already exists. So if we can offer reassurance to this population, even doing nothing else, as long as we have ruled out other contributors, likelihood of improving quality of life for that woman in pregnancy and achieving success is pretty high. Genetics, if either of the parents is a carrier of a translocation or a structural anomaly, they do have a background probability of conceiving spontaneously with a normal, genetically normal conceptus. Expectant management is possible, but IVF with genetic testing does have a place, and in our part of the world, donor gametes. So I'd mentioned to you, whole exome sequencing is the burgeoning frontier in trying to understand what other contributors exist, modify your lifestyle. I'm not going to go through this. Some data about luteal starter vaginal micronized progesterone improving live birth in women with recurrent pregnancy loss. APLS, so heparin aspirin does not work in any condition other than antiphospholipid antibody syndrome. So really no need to be treating patients who just because, but only in APLS. IVIGG, intralipids, in endometrial natural killer cells, immune profile, partners leukocyte infusion, really no role. Chronic endometritis, this is a study which really is an observational study. Essentially what it's underscoring is this top line that women who had chronic endometritis and were treated, repeat assessments showed resolution of chronic endometritis. They were followed longitudinally, had a markedly higher live birth rate compared to women who were treated but did not get resolution of chronic endometritis. In the midline is our women who did get normalization of one parameter of endometritis, but not another parameter of chronic endometritis. So treat chronic endometritis, reassess, make sure that it has been resolved for this patient population. I'd already talked about pre-implantation genetic testing, does have a role, comes at the cost, financial cost. It reduces interval to pregnancy. So older women, they may want to utilize this option. Lastly, really to mention, there is a role of embryoscopy. So we are now doing more and more of hysteroscopic evaluation of clinical miscarriages to try and identify structural anomalies. Panel on the left is one of fetoscopies, embryoscopies that I had done, where this was a loss where we could see nuchal translucency in the embryo, and eventually this was a genetically abnormal embryo. But panel on the right really identifies that even in euploid losses, patients who have recurrent pregnancy loss, many of the euploid losses are structurally abnormal. So when you have structural anomaly, you're probably looking at an epigenomic phenomena going on. But you can give closure to the couple by saying it may be genetically normal, but it really was not normal. So evaluation in our part of the world, we want to send for histopathology. We are quick to getting a karyotype because a genetically normal embryo, products of conception, then you go and evaluate the rest of the things that I've talked about. If it's an abnormal karyotype, you karyotype the parents. If the parents are normal, you reassure, and then you reassess. Whereas if the parents are abnormal, they have the option of expectant management versus pre-implantation genetic testing option. They also have an option of karyotype. So take home RPL is uncommon. Prognosis is reassuring. Tender loving care really does work. Address the addressable, karyotype the products. Embryoscopy is something that I would encourage gynecologists to gain comfort in it because we may have some answers going there. And with that, I really want to thank you for this opportunity. I think I've extended in my time, so sorry about that. Many thanks.
Thank you very much, Professor Lubna Pal. It was a really very, very enlightening talk, and thank you very much for bringing in the newer concepts of euploidy and eploidy comparisons. Thank you. It was no doubt you took extra time, but we all thoroughly enjoyed it. Thank you very much for that. Let me introduce my next speaker for the session, Professor Jeanne Conry. are glad and we are fortunate to have Dr. Jeanne Conry among us at this speaker session. She is currently President-elect of FIGO, past President of ACOG. She is leading the Women's Preventive Services Initiative. She has led efforts on quality and safety in maternity care through improved standards and responses in high-risk obstetrics. Dr. Conry was an obstetrician gynecologist at Kaiser Permanente. She developed the Women and Children Center, the largest obstetric delivery service in Kaiser Permanente. She is president and CEO of the Environmental Health Leadership Foundation. She is executive board member of FIGO, and she co-leads their working group on reproductive, developmental, and environmental health. She has received the Visionary Leadership Award from the University of California and the U.S. House of Representatives Acknowledgement for Accomplishments in Women's Health. He is former associate clinical professor at the University of California, Doctor of Philosophy and Biology from the University of Colorado. Madam Jeanne, thank you very much for joining us. Dr. Conry is going to talk about the futuristic options. How can we invest for future for health service delivery and teaching? Dr. Jeanne.
Thank you very much. Let's see. There, I should be on screen sharing. You can hear me well?
Yes.
Thank you. I am delighted to be part of the Society of Obstetricians and Gynecologists of Pakistan meeting. I'm honored to be part of this illustrious panel because the previous two talks have been incredibly impressive. My thanks to President Raza Correjo and to yourself, Secretary General Halima Yassin, and to my colleague with FIGO, Dr. Rubina Sehal, and Dr. Sadia Pal, who first introduced me to the colleagues within Pakistan. Someday I hope to not be there just for a virtual meeting, but for an in-person meeting, because you accomplish so much in a host of different settings that I think really challenges. I know when I met everybody in Sri Lanka, listening to what it took to get to the meetings for some people was just amazing. And I am indebted to being here. So thank you. I have no conflicts of interest to declare. And I really am going to take this from a perspective of health. I'm talking about innovations, but really when we talk about innovations, I want to challenge us to view our delivery in terms of outcomes and not necessarily process. And innovation just for innovation's sake isn't what we need, but we need to look at our entire healthcare system. I will be identifying some of the future revolutions in health outcomes. And Dr. Paul, I loved your talk, listening to it. So I think there's some tidbits on endocrine disruptors that I will mention. I want to recognize what our potential is for innovations and really look at some low and high fidelity training when it comes to medical and OBGYN training. It's the World Health Organization that has said health is a state of complete physical, mental, and social well-being, not merely the absence of disease or the absence of infirmity. And I want us to keep that perspective because in the end, it really is about the health and well-being of the women that we serve. So when we ask ourselves, what is it that we want for our patients? And then the flip side is there anything that we can control? For our patients, I know that we want to serve their heart, their soul, their body, their minds. We would love them to have a healthy life, healthy choices, disease-free, optimized health, a quick response to their needs, and prevention rather than treatment. But to be able to be there when they do need treatment. We know that mental health and empowerment is absolutely critical for our patients. We know that we're plagued with the social determinants of health, poverty, and the circumstances of their lives. But as physicians, we know that we need to hone our skills, that we've got to be the best that we can be. We've just heard two fabulous lectures about what it is to have the most up and coming medicine, and the techniques, the skills, the knowledge base are critical. We also need the time to address our patients' needs. We've got the technology, up to date, speed. Those are all the ideas that come to my mind when I talk about physicians and our patients. Are our goals compatible? Well, we look at the goals for our patients, and it really is that they can lead their lives to the fullest. And we want to be able to be there for them in empathy and caring, and also in technology. I first want to share one of my favorite articles. This is from Dr. Katz. He wrote it in 2009. The article could be rewritten today in its entirety and be the same. It's based on the 1993 summary by the Centers for Disease Control, looking at the causes of death in the United States. And the Centers for Disease Control said that there were 1 million premature deaths. We know that we're all going to die, so they said these were premature. And what they looked at was the circumstances surrounding those deaths. And they said, when you come down to it, you can put those 1 million premature deaths into 10 large categories. If you will, cardiovascular disease, stroke, cancer. But when it comes down to the root cause, the number one root cause for all of these deaths was tobacco. And if you looked at the 1 million deaths, the three major causes were tobacco, lifestyle choices, meaning not having an adequate diet or an improper diet, and not getting exercise. So three major causes for 1 million premature deaths. And that's why Dr. Katz called his article, Life and Death, Knowledge and Power, Why Knowing What Matters is Not What's the Matter. He also called it Healthy Living is the Best Revenge. And this was published in 2009. 2013, when the CDC came out for their 20-year summary, the findings were exactly the same. And I would gather that in 2023, it will be almost the same, although who knows what the COVID major hiccup will have there. But it really, when we're talking about prolonging lives, it's on healthcare prevention. And I want to keep that in mind when I talk about innovations. So innovations, where do we go with those? Well, certainly this year has seen some of the most impactful innovations because we've been forced to. We heard about virtual meetings, virtual conferences, our webinars that we're sharing in, but we also are seeing that with our patients and telehealth. Now, this graph looks at a 60% reduction in ambulatory practice visits over just a couple of month time period. I would say that a number of those ambulatory practice visits were converted to telehealth. And in the case of Kaiser Permanente, they were video visits, a whole system to have a video visit so you're able to see your patient, speak with your patient, get information on their blood pressure, their weight, and assess their well-being. Will we be able to continue that is the most important question. Is there a need to continue televisits, and what do they offer for us? Dr. Nate DiNicola with the American College of Obstetricians and Gynecologists has a telehealth intervention group, and they've looked at some of the outcomes in obstetrics and gynecology. In this review of about 4,000 abstracts, 32,000 patients, they said particularly when it comes to what I call high-touch outcomes, they found very good success. They saw that with a telehealth intervention, there were improvements in smoking cessation and increasing breastfeeding rates. They also found that they were very effective for increasing continued use of contraception or being able to adjust contraception very effectively. And in fact, even with the high-risk obstetric group, they found that they were able to see decreased need for monitoring and no decrease in poor outcomes, meaning they were able to maintain good outcomes, but decrease the monitoring just by contacting the patient and having good follow-up. They also said, if we're looking towards the future, we could look at home tests for HPV and STDs. A patient is actually able to do some of those tests on their own. We can do telemedicine for blood pressure, weight, lifestyle, and for exercise. And for those of you who talk about pregnancy as the window to women's future health, we know that there are 5 major complications of pregnancy that predict cardiovascular disease 10, 20, and 30 years later in a woman's life. What better way than to have a video visit as a 6-month postpartum to eyeball the patient, get her blood pressure and her pulse, her weight. She can have all of those available for you, and have a discussion about her long-term health care. So there are ways to juxtapose what we've seen with COVID, learn from that, and say that these innovations are actually timely and we should continue them. We can do remote monitoring. There are now contact lenses that can be used for remote monitoring of disease states, wearable monitors, and then app-based information. There's something called the Global Innovation Index. And the Global Innovation Index really looks at the next year and the next decade to predict how we're going to be able to innovate, and particularly around healthcare choices. INSEAD and Cornell had a partnership to review the drivers of change for the next decade. And they said that there are 5 trends that will be driving the world. Number 1, the information revolution. And this information revolution goes hand in hand with broadband access. The better access we've got to internet, the better access we have to communicating with our patients effectively, and the better access we have to webinars such as this so that we're able to share information. We can harness artificial intelligence and use information how to evaluate and predict disease processes with algorithms and the like. We can have targeted treatment. We heard a great Dr. Mirza talking about targeted treatment and what that can do. We know that targeted treatment can make a difference in our patients' lives. They've also said consumerism, as much as some people listen to that and think, oh my gosh, what do I have to do here? Consumerism is actually pushing us for change because our patients are asking what we can do better for them. So listening to the patients and their needs is critical. We said I chair the Women's Preventive Services Initiative for ACOG, and that Preventive Services Initiative is listening to consumers and pushing out to consumers on what we need to do better for women's preventive health care. And then finally, many talk about healthcare business models. And that may not be something that we think about so much when we look at a healthcare system, universal healthcare. But I would say when you get very specific companies looking at models, that we will listen to that and they will be there to integrate change. At the same conference, the National Institute of Health identified what they called the emerging technologies. This was at a World Economic Forum. And they said these 10 medical breakthroughs will change the world. I think we've already heard a couple of them mentioned this today. The first 4, I would say, are a little bit beyond our area: brain mapping, Alzheimer's, spinal cord injuries, and single cell analysis. But pain management, we know, impacts OBGYN in terms of maternal mortality, in terms of maternal health, and in terms of chronic pain patients that we have. Regenerative medicine is looking at what we need to do specifically around cell care and how we prolong lives and what we can do to manage that. We've heard about cancer immunotherapy today. We've heard a lot about vaccines in the last several months. The Nobel Award went to 2 of our physicians who have been key in CRISPR and gene editing. And then we just heard about precision medicine. And I would talk about precision medicine, not just in terms of the genomics, but in terms of the exposome. We know that it is a complex relationship between genes and our environment that overall impacts our health. And until we can grasp the impact of the environment, we will not make these changes. In fact, we know when we're hearing some of these talks that we'll talk about a 3% contribution of the genes, or sometimes a 15% contribution. That means literally 85% of the contribution is not the genes. And I would hazard to guess that it is a strong evidence of impacts of the environment. We know that in the last 30 to 40 years, the very large increases that we've seen in poor outcomes, whether it's autism, diabetes, ADHD, or we've seen decreases in sperm count, cannot be explained by genes alone, but they can be explained in the context of endocrine disruptors. So when that idea of precision medicine, we can bring about changes. But in terms of all of the innovation we have, one of the questions that we have to ask ourselves is, how should we be teaching? And the flip side of that is, how do we learn? And what studies we can look at. I love this one by Dr. Rolfson and his colleagues, because what they said is that there's a strong push to have innovation in education. And their article says, innovation in early medical education, no bells or whistles required. They surveyed a large group of students, and they put together 6 innovations, or 6 modalities, I should say, in medical teaching, some with the bells and whistles. So they had strong video games, video learning. They had some that had partners with other students, fellow students, and some with games, not necessarily video, but challenging them on one-to-one instruction with fellow students. So 6 different modalities. One end of the spectrum was a simple patient-provider interaction. And they looked at perception of the best outcomes. And the perception was from the medical students. Under which of these 6 modalities did they feel like they learned the best? 97% of the students said for teaching a physical exam and understanding how to work with a patient in assessing their needs, the number one was the one-on-one contact with the patient. Now, these are very early students. They were not in the surgical specialties per se. They were learning how to examine patients and take a history. But that says that we don't need to necessarily worry about the bells and whistles, our low fidelity, if you will. But then we have high fidelity. Dr. Cook and the Journal for the American Medical Association looked at students, and I think it was about 35,000 trainees who are going into various aspects of the surgical world. And they looked at those students. They reviewed 11,000 articles looking at their students, 137 studies in the end met their needs. And they said the number one was technology enhancement with simulation. They found that you could go from no intervention to the other extreme with anything that enhanced technology and simulation technique. And for surgical skills and for the learning environment overall, the number one was a high-tech environment. They saw improved knowledge, improved skills, and improved behaviors in responding to crises. And I think every one of us can relate to that when we've been in simulation and drills and know how important that was for honing our skill set. But their caveat was the patient-related perception was not improved. So low fidelity meets high fidelity. We've got to think about both. When the American College of Obstetricians and Gynecologists in 2017 said that they needed to review our training overall for our OBGYN residents, they held a summit that extended over a better part of 2017. They said the number one thing they needed to do after that summit is align the curricula across the United States so that there was a consistency in training. Number two, they had to devote time to their faculty to make sure that the faculty were prepared and ready and had the skills and support to create change. The third was that they needed to prep the medical students. So once a medical student knew that they were going into OBGYN, how do we use those last few months of medical school to prepare them for the OBGYN training that they needed? And number four is revamp the curriculum. When they revamped the curriculum, they established core competencies in obstetrics and gynecology. They said, number one, they needed to look at patient care and procedural skills. We need to be able to talk about both of those and make sure that the setting for the skills is in the context of what the patients need. They needed to keep a very strong medical knowledge base and hone that at every step in the training. They needed to focus on practice-based learning and improvement. And here they challenged the clinicians across the United States to look at what that was going to take and how they would be able to provide for the needs there. And again, very pertinent to this is simulation work. How do you enhance the techniques and the skill sets of these students without actually being able to operate on a patient? And they said all of this is in the context of we know that our care of medicine has changed in the last 50 years. We know that we need to focus on interpersonal and communication skills. We need to focus on professionalism, the ethics, if you will, of our of being a healthcare provider, being a clinician in this healthcare world. And then finally, on systems-based practice. What they said was, when we look at the last 50 years in medical care, we've gone from general OBGYN to major focuses. We've heard, reproductive endocrinology and infertility. We've heard about GYN oncology. We know we've got family-based care. We've got urogynecology. So we've got these major areas within OBGYN. So how do we satisfy the needs of our residents to be sufficiently trained in each of these areas and continue with the professionalism that we require of them? They pointed out it's not going to be simple, but if we don't focus on the faculty development, keep the faculty comfortable, and then create learning for the students, we will never succeed. If you look at the European system, European Board and College of Obstetrics and Gynecology, over the last several years, they've led a major initiative across all of the European countries to standardize their teaching and training, and then to standardize the testing system. It's been an incredible change, and they're very proud of what they've accomplished. And I know that the trainees are very proud of what they've accomplished. If we go and look at the Royal College outlines their competencies in a large compendium and updates those on a regular basis. So you can look at every single one of the competencies that a trainee should have from the Royal College, very much like what ACOG has done. You can go down word for word on what the competencies should be and how to assess them. After the ACOG CREOG system was revamped and reanalyzed, a group of physicians looked at the role of simulation training and said, what is it going to take? And one of the first steps, again, this is looking at both the low fidelity, that one-to-one patient interaction, and the high fidelity, a simulation training. And they said the first step that it takes is having a competent exam and feeling competent with a physical exam. They recommended what are called gynecology teaching assistants, so paid teachers. And now I think 75%, at least 75% of the medical schools have a paid teacher who's able to interact with the medical student and focus on how to perform a history and a physical exam and give them immediate feedback. It's low fidelity with a cost because you have to pay for the teaching assistants, but it's not a high-tech setup. It's one that any medical school with a small budget can accomplish. One system in the Royal College tried that and 99% satisfaction. So those kind of approaches really are very effective. I know in my own Kaiser Permanente system, we took this a step further and found physicians that were a little bit challenged professionally, perhaps with communication. We actually hired actors to come in. We as physicians gave them some of the scenarios so that they weren't coming in with no background. We gave them clinical scenarios and asked them to act out for physicians. And we found that having a physician go through several acting situations actually improved their skill set because they were able to do it in a harmless situation. They were able to get feedback from the actor and from skilled clinicians, skilled people in communications. So anything that improves our communication is actually critical. So my messages are pretty straightforward. Simulations can be both effective, but they can be expensive. So finding the balance between both of those is where we need to go. I don't think any one of us doubts that we've done a simulation training on labor and delivery for placenta accreta and gone through that with an anesthesiologist and all of the immediate feedback. We've honed our skills and we've also honed our communication. It's a very effective one, but it's not available for every situation. It's not available for every academic setting. So being able to look at that combined effectiveness between low and high fidelity is really one of the most rewarding steps that we can do. Sometimes you have to look at paid consultants. I know we hired actors from the Sacramento community. We went to the Sacramento Theater Guild and actually hired them and had them on contract for a year and found it was really valuable for our physicians. We know that communication training is essential, but actors will suffice. So we know it's low and high fidelity that we've got to strive for, but it's always in training ourselves for the unexpected, because that's what we deal with in our lives. But when I look at it for our patients and ourselves, it always is a balance, because the number one issue we have is how do we provide enough preventive health care for all of our patients? And whether we look at the number one cause of death, cervical cancer, for our patients, we can prevent that if we have this set up. So having the greatest impact on health outcomes, we need to focus on prevention. But we also have to understand how difficult it is. We've got to be collaborative, and we know that the social determinants of health can impact everything that we do. We also know that we're facing very rapid changes. So adopting changes can be challenging for each and every one of us. We've just heard two fabulous lectures about the changes that have been adapted, certainly just in a matter of years, about changing in response to the knowledge environment and having to change our practice. So remember what your patient needs are and what you can offer. And I would say when we're talking about the recurrent pregnancy loss, for my hat, I put on endocrine disruptors, impacting thyroid disease, impacting the immune system. So we know all of these should be part of our armamentarium. We know that when we're talking about cancer, there are three major areas for endocrine disruptors: cancer, immunologic systems, and thyroid. So looking at those areas, how can we bring about change? Technology is great. Innovation is the present and our future, but we have to allow time for the research to show what the investments in health need to be. We can hear incredible research, and then it is the closing comments, like we heard from both of our speakers, about what it is that we need to do in our practice in day-to-day medicine. And then we ask ourselves, what's the bang for the buck? Where are we going to put our energy and our time and our focus to help our patients? So it gets back to the World Health Organization. Health is a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. Thank you so very much for having me be here today. I really appreciate it.
Dr. Conry, it was very, very enlightening talk, and thank you very much for bringing in professionalism, the concept of soft skills. Now, I will request my worthy panelists to kindly throw the lights on these concepts regarding the talks which are given by our speakers. So my first question or first query is put to Dr. Fozia, Dr. Rehana Rahim. We have heard the talk and updates on endometrial cancer, Dr. Rehana. So if we can have your views on how medical oncology can work in our national context, and how do you think the enhancement or the improvement in the surgical skills training regarding gynecological surgery can be done in our national context? Madam Rehana Rahim.
Thank you very much, Dr. Halima. Indeed, a very innovative, impressive, and excellent presentation by Dr. Mansoor. We know endometrial cancer is the fourth most common cancer in women throughout the world. And we also do understand that there is an improvement in 5-year survival up till 77% in high resource countries. And low resource countries, we all understand, has got a higher mortality, about 4% higher mortality as compared to developed countries. Now, working in Pakistan, we tend to understage or sometimes wrongly stage the disease for many reasons, like patients coming late. We are not in the habit of routinely performing lymphadenectomies or sentinel node biopsy because of very few centers and very few trained gynecological oncologist surgeons. Primarily, MRI is being used as a modality to stage the disease, but we know it's not very sensitive or specific in picking up micro or macrostatic metastasis. I would like to know, Dr. Mansoor, what are your thoughts? Whether we need to refer these women earlier than later to prevent loco-regional recurrences, particularly in type 2 endometrial cancers, or type 1 endometrial cancer where there is more than 50% of myometrial invasion. This would be my first query. Now, my second query is that we are getting obese women with comorbidities, and we know it's happening everywhere throughout the world. But many of these women are deemed to be unfit for surgery. So what would be your views about the role of radiotherapy as a primary modality and the role of local progestogen as a primary modality in these women? Thirdly, Dr. Jeanne mentioned the role of changing behaviors. I firmly believe in that, and especially propagating the role of prevention of endometrial CA. That is to fight against obesity, which is now contributing to about 50% of endometrial cancers. And I think that would be one of the pivotal turning points in epidemiology of all obesity-related CAs. Thank you.
Thanks so much for great questions. Thank you very much. Let's talk about lymphadenectomy first. So we have not seen that lymphadenectomy improves survival, but it will put patients into the right boxes. You need to give adjuvant treatment or not. If you're talking about early stage, you won't, as I showed you one slide, you don't find out if this is stage 1 disease or not, especially in the grade 3 patients. And as you said, in patients who have more than 50% myometrial inversion, 1/3 of these patients may have occult stage 3C disease. And these patients do require systemic adjuvant therapy and radiation therapy. I don't see that lymphadenectomy should not be performed. We have to find, yes, if it is stage 1, grade 1 endometrioid adenocarcinomas, less than 50% invasion, you can skip lymphadenectomy. The risk of lymph node involvement is minimal. But on all other cases, you need that. And if you're not doing that, that is the case we had for a very long time in Europe, and we are still fighting with that. In that case, I would treat them as if they had advanced than stage 1 disease because of the risk, which is so high as 30%. And then I would treat as it is. What is your treatment of choice in the country regarding radiation therapy and chemotherapy? So that would be the case both for type 2 disease and type 1 disease. For the type 2 disease, I think it's even important if it is stage 1 less than 50%, but you have p53 mutated tumors, you would see high risk. So I would go ahead and treat them as high risk. So that's why you will see that classification we have made. These patients will automatically move down to a high risk group and receive the treatment as it is. I think the most important thing you are mentioning also when it comes to obese patients, and here this one, is the lack of centralization of surgery in the country. This is alpha omega. I can give example. We in Nordic countries, we are fortunate. All treatment is centralized, completely centralized. There is no private. It's all centralized treatment, ovarian cancer surgery in whole country in 4 centers only. That has alone improved survival in the real world evidence by 10%. So what you need is, and that's a difficult part. It's a very politically very difficult part. We had to go through the parliament to do that. I think the best thing you can do is the referral of these patients as soon as possible to the center of excellence, to the multidisciplinary team, so they can take a decision how to treat that patient. The same is with the obese patients. Today, it's not a problem to perform a surgery for obese patients in the highly excellent centers of excellence. With the anesthesia available, the quality of anesthesia. I know that is difficult in Pakistan. I would very much like to not to just throw surgery, which is one of the most important part, by saying that this is not possible. Maybe in this hospital, I would rather transfer that patient to a better I'm seeing better in the way of multidisciplinary team available, so we can perform the surgery, because surgery is the most important thing for these patients. You cannot replace surgery with hormonal therapy that's palliative in this setting, or with radiation therapy. We have been using capsules, and I'm radiation therapy as well, therapist as well. No, this cannot replace surgery. So you have to try your best for going for surgery, also for the obese patients. Okay, we do have the robotic surgery available. That's not available in Pakistan, but there are quite good anesthesia help and multidisciplinary team available. So that would be I do not want to make a statement, you may replace surgery, because then everybody would say, well, that's a possibility. No, definitely not.
Thank you very much, Dr. Mansoor. Thank you very much for your views.
Thank you, Dr. Hana and Dr. Mansoor, for very relevant comments and queries being discussed on this important issue of CA endometrium. May I now put a question to my second panelist, that's Dr. Fawzia. It is related to recurrent pregnancy losses. Dr. Fawzia, how would you recommend touching to this sensitive area in our women? We don't have those kind of genomic tests available. How do we go to treat these women? They also need our treatment. Dr. Fawzia, over to you, and then you can talk to Dr. Pal about it.
You're mute. Please unmute yourself.
Can you hear me now? Okay. Thank you, Dr. Halima. First, I'd like to appreciate Dr. Sadia Pal and Abbott team for organizing this excellent symposium, and an excellent presentation as usual by Dr. Lubna. My comments related to the challenges that we face in Pakistan. One was already highlighted by Dr. Lubna, that we really do not have any local statistics as to know what is the actual incidence in our population. We may be aware of the risk factors, but we really do not know the incidence. But nevertheless, we all deal with such patients all the time. And one of the challenges that I feel I come across, that majority of these women who have a history of, let's say, 3, 4, 5 miscarriages come to us when they're already pregnant. So that becomes a very difficult situation when you cannot establish a diagnosis and how to treat and manage these patients. The other aspect, considering our population's affordability, is the cost of the investigation. And I have a breakdown of what it costs to, let's say, just get a antibody profile done. That goes up to like 30,000 rupees. And then if you go for karyotyping, that's 10 to 15,000. Majority of us are unable to get these investigations done. And then I think a lot of mismanagement at the periphery level when these patients are dealt by the local gynecologists. They've already spent a lot of money on doing investigations which are non-evidence based. For example, majority of them would come with a torch profile. And now we all know that for recurrent pregnancy losses, there's no role for doing a torch profile. So I think educate more than the patients, our community of the local OBGYN community, especially at the periphery level, requires awareness as to what is the evidence-based approach to investigate and manage these patients. So these are a few challenges that we faced. And another comment that I'd like to make is that Dr. Lubna was quoting the ESHRE and ACOG guidelines. There is a lot of difference in what the RCOG guidelines are saying. So what I feel as a trainer and an examiner, majority of our candidates who are preparing for FCPS are reading the RCOG guidelines, which still stick to the old definition where you have to wait for 3 recurrent pregnancy losses before you start investigating. So these are the few challenges I think which need to be addressed. And I just have a couple of questions for Dr. Lubna. That if we do encounter, and we do encounter such patients who come to us who are already pregnant, how to manage these patients. Which patients would be candidates where we would go for the thrombophilia screening? And is there any role in these patients for the platelet-rich plasma therapy, which was at one point mentioned for dealing with patients who undergo recurrent implantation failures in IVF treatment? Would there be any role for using the same therapy for patients who are encountering recurrent pregnancy losses? And we have a question, I think, from our audience regarding treatment of endometritis, which I would like Dr. Lubna to comment on. Thank you.
Thank you so much, Fawzia. First of all, thank you so much to SOGP, to all the organizers for this opportunity. And thank you for allowing me to be a part of this August panel. It really, what a wonderful session. So thank you to my co-speakers. Fawzia, before I go, and thanks so much for the questions. Fawzia, before I go and answer your questions, I just want to make a few comments. Thank you for sharing the challenges. I have to sort of underscore my perspective. We cannot approach this by looking at what we cannot do. We have to approach it by looking at where are the possibilities, what we can do, right? I do believe history, patient's history, her obstetric history, her personal history, her family history tells us a lot of snippets. We can, if we are able to do histological evaluation of what is lost, we can gain some understanding. We can be focusing on having central, we don't need an urgent, frozen section pathology. We can have a centralized approach to have products of conception be evaluated by somebody who's a GYN pathologist who can work. So it requires a little bit of an organization across the country, through big centers. Maybe SOGP can spearhead such an effort. So histology of products, whatever is passed out, if we can focus on evaluation, we will gain some understanding. Having a centralized place. So if you think about karyotyping of products of conception, the actual technology is not expensive. There are now kits available. People have in-house all you need is a technician. You don't need a PhD for that. You need somebody who is able to go through and follow a recipe, but so thoroughly that your data are reliable. So if only at the level of big institutions, provinces across the country, I mean, in the PIMS and Abira, you could sort of give us a sense. PIMS has got such a huge laboratory force there. So I don't think we can justify the cost of karyotyping in today's day and age. We just need a systematic approach to centralize that effort. I think evaluation of the endometrial cavity by a office hysteroscopy. Once you buy the equipment, it's really your time. So there is no reason for us to be escalating the cost of endometrial evaluation. If we can just centralize a few places, we can subsidize the cost of endometrial evaluation. The moment you do a hysterosalpingogram for endometrial cavity evaluation, not only is there the cost of technology, it's the cost to the radiologist, it's the cost. So much cost gets spread out, and that is borne by the patient. But if the clinicians take on that responsibility and create a center, you don't need a center in every institution. You can have one place where women could be evaluated. So I really do believe there are so many opportunities to reduce the cost for the sake of the patient in a systematic manner. As regards the questions about thrombophilia screening, one more before I go to thrombophilia screening. We have got to move away from teaching to an exam to learning for the sake of understanding the physiology and the pathophysiology. So the people who are preparing for MRCOG exam, they have to get out of that box. They need to, in today's day and age, knowledge is at the click of a button. So I cannot justify somebody just following one curriculum for the sake of an exam. They need to be knowing and understanding the information that is out there. So for all our trainees, if somebody is listening, you got to get out. You cannot just prepare for an exam. You prepare for the field. That's what we need to do. Coming back to thrombophilia evaluation, it's really late pregnancy losses. Patients with history of preeclampsia at an early gestation, that could be a hallmark of an underlying thrombophilia. Premature cardiovascular disease, clotting in the family. And late losses. So 6 week, 7 week loss, you don't have to jump at doing a thrombophilia panel. Recognizing that as a woman ages, she may have inherited thrombophilia, but may have no clinical stigmata. But then as she ages, the older age makes her phenotype change. So that too is a phenomena. But thrombophilia should not be the first line of evaluation. TSH, why can we not subsidize TSH screening? Of all the endocrine evaluations, seriously, check the urine for glucose. Is she spilling it? Is she dysglycemic? You don't need to do hemoglobin A1Cs on everybody, but putting some thought process to say, what are the endocrinopathies that could predispose to RPL? Thyroid is one thing that needs to be looked at. Goiter, iodine deficiency. I remember when we were at the couple of years ago now, when we had gone on the medical mission in the north, so much of goiter out there. Now that's probably nutritional goiter. So iodine deficiency is so common. So I do suspect thyroid aberrations are prevalent in our community, and thyroid should be looked at. As far as PRP, lots of hope and promise is attached to PRP with very little robust data to back that up. So beyond implantation, PRP should not have, right now, there are no data to suggest a role of PRP in recurrent miscarriages. Now, could PRP have a role in the biochemical losses? That's a question to be asked, because why did that pregnancy not progress beyond the earliest dialogue between the embryo and the endometrium? Is that a problem of the embryo? Is that a problem of the endometrium? So in the ART scenario, we can tease off those things and maybe examine a relevance of PRP for a very small sort of category of earliest losses. But as far as placentation having been established, there is a whole slew of growth factors that have been brought into to play now. So I don't expect PRP, just in terms of biological plausibility, of having much relevance beyond the earliest stages of implantation. As far as treating chronic endometritis is concerned, step one is my recommendation, strong endorsement. We know so little about chronic endometritis. We are dependent on histopathologists giving it a call. Right now, histology is the diagnostic tool for chronic endometritis, and there's no consensus amongst pathologists. How many plasma cells? Should we be doing CD138 staining before we call a specimen chronic endometritis or not? if we could have centralization of chronic endometritis. So that means gynecologists having a conversation with pathologists to create a consensus that, because now the field is going towards not just plasma cells, but stromal changes should be there in the endometrium before you call it a CE. But when you call something a chronic endometritis, doxycycline is a bacteriostatic agent with a very limited spectrum of coverage. So don't use doxy as your tool, which is so commonly utilized globally as the antibiotic for treating endometritis. So based on studies where cultures were done on endometrial tissue, based on studies where microbiota were looked at, really a broader spectrum needs to be utilized that should cover the GI bugs. So enterococci should be covered, gram-positives, gram-negatives should be covered, anaerobes should be covered. So in our practice, we do a triple regimen. So we used to use doxy, but GI tolerance is not that great. So we use azithromycin, just a Z-Pak 5-day course, plus metronidazole, 500 milligrams twice a day for a minimum of 14 days, and ufloxacin, Cipro can be used as well for 14 days. Once we have completed the regimen in a subsequent, so one menstrual cycle later, repeat the biopsy to make sure you have cured the problem. About 1/3 of patients, you get improvement in plasma cell density, but you still see stromal edema, you still see whirling of the stroma. And those are the patients who require another course, and up to 3 courses have been described in literature. So the broader spectrum antibiotic, longer regimen, pay attention to repeat surveillance to make sure it has been eradicated. So those are my thoughts. I think I answered the questions, Fozia.
Thank you, Dr. Fozia and Dr. Lubna.
Fozia, mute.
Fozia, you have to unmute yourself.
Yeah, okay. The host.
We need to unmute Dr. Fozia so that she can give her final comments.
Can you hear me now?
Yes, madam.
Hello?
Yes, Dr. Fozia, we can hear you.
Okay.
We
can hear you, Fozia.
Just another, the host had actually muted me, so I had to ask her to unmute me. Just another comment and a question. We were talking about the karyotyping of the products of conception. Now, a lot of us obviously opt for medical termination of pregnancy for first trimester miscarriages, and in that situation it's not possible to get a karyotype done. So would you recommend that patients who have this history should get a surgical evacuation to be able to get a karyotyping done? And the number 2 comment is yeah, please.
Thanks, Fozia. So
how would we ensure the karyotyping if you're going to
So Fozia, thank you for that question. Firstly, I do not recommend surgical management just for the sake of getting the tissue, unless you are in a center where people are cognizant about the need for gentleness of surgical intervention under ultrasound guidance. We are reverting to doing hysteroscopic collection of the sample, so that we don't have to do a DNC where we are doing a global scrape of the entire uterus and rendering. I am seeing so much of Asherman related to Ds and Cs. So there are plenty of data now.
Yes, when I talk of surgical evacuation, the hysteroscopic evacuation.
So hysteroscopic evacuation, where you are collecting trophoblastic tissue or embryonic tissue directly, is a pretty, I really think that's the way of the future to get the data without causing harm, but the cost has to be brought down. Patients who pass products through medical management can be given containers to collect the tissue, and that tissue can be karyotyped as well. With the traditional karyotype, where you are looking at metaphase stage of cell division, there is about 1/3 failure of karyotypic analysis because cells don't grow. when patients pass the tissue and bring it to you. But 2/3 of those cases, you get a reliable signal. But if you have tissue that they bring where histologically, I have been unable to get a karyotype based on traditional testing, but histologically villi are visible, microarray approach, SNP approach can give us genetic information. That requires us to work with a reliable lab. These are not expensive. When the moment you go high throughput technology, these are not expensive tests. I think talking to the Tahir Shamsi's center in Karachi, where they are focusing on genetic testing for thalassemias and all that stuff, they have the technology, they have platforms available. If you could match up with institutions like that to have your tissues examined, it'll bring the cost down.
Yes. Thank you, Dr. Lubna, for bringing in that point. So my next question is to Dr. Abira Chaudhry. Dr. Abira, keeping your background in medical health, professional education and training, let me ask you a question relevant to Dr. Jeanne's talk, that she has talked so wonderfully about innovations and the use of technology in providing healthcare as well as for education and training. How do you think, you being an educationist yourself and being involved in postgraduate trainings, how do you think in our national context these models of healthcare provision as well as training can work, and what do we need to do about them?
Thank you. First of all, I would like to congratulate Professor Jeanne for such a wonderful and excellent talk. It was such a treat listening to her, and it was so enlightening. It got all of us into thinking as to how we can plan to collaborate, so that we can also, have these exciting innovations translated into our practice. Well, to start with, I would say that though the COVID pandemic disrupted the healthcare system, of both the rich and the poor nation like us, we use this opportunity to improve our services. Me working and looking after the armed forces families, we especially felt that we took this opportunity, and made a great improvement in many ways. Telemedicine was really in its, I would say, pre-infancy stage in Pakistan. And the COVID pushed us at least a decade forward, into telemedicine. And this has been the experience, not only with me in the armed forces, but also anecdotes have been shared, by, people who are in other healthcare systems in Pakistan. It may sound very primitive to our international speakers, but we do not have an appointment system in Pakistan. Right? Anybody who wants can just walk into a hospital. Same goes for our armed forces hospital. There's no way of triaging as to who actually deserves to go to the hospital. And so first thing in the morning, thousands of people gather in the outdoor departments and, filling up all of the waiting area. And then the same crowd then goes and lines up, huge queues outside the pharmacy. So we introduced, as soon as the COVID pandemic came, we introduced an e-appointment system. Previously, we had tried to introduce an appointment system in the armed forces many times, but it always would turn out to be a disappointment because it's so difficult to change human behavior, and there's people just want to stay in their comfort zone. So now we introduced immediately an e-appointment system. Via telephone, there was virtual care. You would start with triaging on the phone, and the calls were taken by doctors or paramedics. We also made a filter clinic, outside a hospital in a primary care area, where we put this huge big tent, which was open on all sides, where women would gather with social distancing, and as many patients we would sort out there with a junior consultant, and only patients who needed to be referred would then walk into the hospital. Also, for a lot of benign gynae, telemedicine facility was available, where a junior consultant or an SR would sort you out virtually on an audio call. We still do not have the facility for FaceTime. And following teleconsultation, the patient would then come and collect the medicine from the hospital through a drive-through facility. And medicine would lie packaged, ready for pickup after working hours. That's after 4 p.m. So we introduced this facility, and for senior citizens, for patients with a disability, and all those patients who contacted us for telemedicine outside Pindi, we would deliver the medicine via mail. So we liaised, in the armed forces, we liaised with the Pakistan postal system, and they gave us, very reasonable rates. It wasn't very expensive, and within 24 hours, the medicine would be on their doorstep. Then all this was possible because we already have, so for the past 10 years, we have an HMS system in our hospital. So with the same HR, we managed all this. All we had to do was to introduce a few more computers and a few more links. And so it was quite affordable. And we kept in touch with all the other hospitals and organizations in the country through regular webinars. And so we all had a taste of, digital health technology. Professor Jeanne talked about artificial intelligence. We used this for our HRCTs for COVID positive patients. And it was using this artificial intelligence that we would know how much of the lung was affected, because our radiologists initially were not able to interpret these HRCTs. Another thing we found very useful was that through the telemedicine, we were able to talk to our entitled patients who were in remote villages and had no access to healthcare services in this lockdown. They didn't have to travel, and they would receive their medicine at home. Now, another thing we found very important here was that because of telemedicine, there was a lot of satisfaction in patients who had COVID-19 and who had mild symptoms or who were discharged from the hospital. So we have a 24/7 facility of a COVID cell where we would use, multiple platforms, either phone, WhatsApp, message. So they would always have a doctor, take their call and then advise them on telemedicine. Coming on to teaching and training, as Professor Jeanne said, so here in the pandemic, obviously immediately for preclinical teaching, everything became online. And later on, we got the students and staggered them onto various floors, the clinical students. And all the lectures and all the CBLs were done online. Virtual teaching, sounds very exciting, but obviously we in Pakistan need training for it. And regarding simulation, we are many decades behind you. For postgraduates, we took this opportunity, and for the first time, we introduced workplace-based assessment, a formative tool for postgraduates. So we launched mini CX, DOPEs, OSATs very formally because we had the time, and then we had the resource while B9 and Gynae was paused, and so was cold surgery. So, we launched this, we took the opportunity. Another thing, I don't know whether it's an innovation or it's going back, is that it was a dream to have a junior labor ward resident cover for the entire 24 hours to improve our services. So for the first time, we launched this, and this resulted in a 40% decrease in our cesarean section rate, a dramatic increase in our VBAC rate, and some increase in instrumental delivery rate. And therefore, because it's close supervision, our postgraduate trainees were very happy, and this also trickled down to better patient care.
Thank you, Dr. Veera. Thank you for sharing your experiences during this COVID pandemic. I must congratulate you and your team for all these innovative activities. So would you like to put up some question to Dr. Jeanne, or should
Yes, what I wanted to find out was that, we as teachers, as medical teachers, we are not trained into virtual teaching. And so, we need to train the trainers. So could we collaborate in any way, so we can be better at virtual teaching and simulation?
I think that's a great suggestion. I think what we've looked at, certainly through FIGO, is that train the trainers is probably one of the most valuable steps that we can take. Because if we can get a whole group of us who are already approaching, whether it's a topic or an area that we want to cover, and then we can train a number of like-minded, it's actually a very valuable way to go. And then looking at where the changes need to happen in the healthcare system that you have. I certainly have heard from my colleagues that there's a centralization that is most valuable, to find out how you centralize care. Within Kaiser Permanente, we're a health maintenance organization, so very different from the rest of United States medicine. But our focus has always been on preventive health and then centralizing. So I think with your background, centralizing care will be one of the most important steps that you can all do. But I also realize that the downside of that is the transportation, the hurdles of localizing to different areas. It's hard enough for me in the Sacramento area to tell somebody that they've got to drive 2 hours for a certain surgical procedure, or even an hour to do something, whereas I'm sure that's even a bigger hurdle for what you're facing. But train the trainers is quite valuable.
Thank you, madam. Thank you, Dr. Jeanne, for bringing in the concept of having a bunch of trainers available who are like-minded and who can work on standardized protocols of training on high as well as low fidelity, as you mentioned earlier. Now the time to have the comments from both the chairs of the session. May I request Dr. Shama Munim to give her comments as a chairperson for the session about all the talks and all the comments which were raised by the panelists.
Thank you very much, Professor Halima. It was indeed a pleasure. And the whole afternoon was so just passed by. And it was all the enlightening talks. And I was receiving a lot of comments from my trainees also, and was answering at the same time. And, it's been very well taken. And I would like to sort of comment more on Lubna's talk, because it's like close to my heart and my speciality. And I'm glad that you brought the subject that there is no role of torch infection, but and the more relevant thing which we are in process of doing is the karyotype thing, and things will move. Because a lot of time people are actually working on the APLA workup and forgetting about the endocrinological problems which are more relevant in Pakistan, like diabetes. From Jeanne, we heard a lot of things that how we can incorporate our virtual things, web-based learning, and how things can evolve. And Dr. Mirza talked about the development of how oncological input into surgical can help us in managing oncology patients. I would then ask Sadia to take over from here.
Dr. Sadia, your comments about
yes, thank you,
all
Professor.
the talks.
Yes, thank you, Professor Shama Munim. I will just carry on, and it's been a pleasure. As Shama said, the afternoon has just gone by, and we've been entertained, literally. And first of all, Professor Mirza's talk was very comprehensive. We being clinicians, we tend to just not know really what happens to our patients after we've operated on them and referred them. So it's so nice to get updated on what the radiation oncologists and are doing. Because we do initially give some sort of counseling once we've finished with the patient and finished our surgical job at least. So it keeps us updated, and thank you so much for your talk. And as far as Lubna is concerned, well, of course, Shama has already commented, and it's been a pleasure, always very comprehensive presentation. And Jeanne, your presentation was also very enlightening and opening a window to the future as to how we should be proceeding from here post-COVID. And just to let you know that we did go a step further in learning and innovation here during COVID, and we learned to teach and train through Zoom and telemedicine, as whatever you may call it. We used Socrative to do a pre-test and post-test, and were able to set up a helpline, a telemedicine helpline, the SOGP and Aman, which is ongoing at the moment. It's a specialist helpline. Very interesting what you said about the teaching methods for med students. And before you even said it, I think we all could have guessed it's the patient interaction which is going to be the winner. And it's true, and it's kind of a proof. And we do trainings, we use OSCEs for structural training as well as evaluation. And that really helps in learning, in my opinion. One thing I would like to ask, and maybe add or ask your opinion, is that in the final year, I think med students, apart from clinical training, and even for residents, they need to go through a values clarification training as well. Because especially when, SHRH issues, things like abortion are so contentious, not just in the United States. I mean, you can lose your election on that basis. It's the same in other countries, in Pakistan also. So it's and it affects women, and we are the ones who are dealing with those issues, and we cannot not teach our med students and doctors to know what their own values are and learn to empathize with the opposite values. So just my thoughts. And if any of the speakers want to add anything, please do.
I will, if you don't mind.
Please
do. I think that's so critical. We do not teach ethics. And in FIGO, I always say one of my favorite committees is our ethics committee, because it does not matter what you're faced with. If you frame it in the ethical treatment of patients, we know what our guidance is. So you are absolutely right on there. I applaud you for those comments.
Thank you so much. If Lubna or Dr. Mansoor want to say anything, or Rubina, who's been there with us as well, Professor Rubina Sohail, our friend, if she wants to say anything, please do before we conclude. This is actually the final session of our virtual symposium. We hope to have a conference next year, a physical conference. So hopefully this team will be there. Yes? Lubna, I see you want to say something.
Yeah. Sadia, first of all, thank you again to everybody. What a delight it has been. I just wanted to underscore something Dr. Conry brought up, which, first of all, absolutely, conversations on ethics it's not a one-on session. It should be a continuous dialogue from the get-go. But I really believe for all parts of this world, investing in training of the educators. I think many of our trainees learned by observing us. And while in theory, we all gain the knowledge, when we are in the trenches, when chaos happens, it's our professionalism that sets an example for them. So we need to really prioritize continuing education and continuing knowledge building and self-checks for us faculty, regardless of where we are. I think that should be a priority.
Absolutely. Thanks. And Dr. Mansoor wants to say something.
I would like to thank everybody, Dr. Sadia, especially for inviting me for this. This is really, really inspiring, and the talks and the discussions were extremely inspiring. And I really congratulate Dr. Chaudhary for what she has told, but what has happened since the COVID started. And I really hope that even when COVID is over us, that you continue the way you are doing it, because we have gone a step further with virtual meetings, with getting medicine to our patients at home, as you just said, by teleconsulting, because that will, if that is continued, you will be able to help many more patients, and the patients who require centralization will be centralized. All others can be reached by video and by telephone. So I think this is a great, unfortunately due to COVID, but this is a great advancement we have. I really hope that soon we will start vaccination. And as you said, Dr. Sadia Paul, next year at this time, it would be a pleasure visit Pakistan.
Yes, so Dr. Halima, who's our Secretary General, and she will be announcing very soon whenever COVID allows us. So we hope to see you all there. Rubina, would you like to say something? Yes.
Yeah, I just wanted to say that what a pleasure it has been to sit in this session and to listen to all these three talks. It was a wonderful opportunity for all of us. And I think with COVID, we have learned one lesson, that the communication in this style is on. And I'm 100% sure this is going to continue despite the fact that COVID will go away. The second thing I think is that Lubna and Dr. Mirza have been here before, but Jeanne, I would like to take this opportunity to invite you to Pakistan. And we hope that things improve very soon. And as president of FIGO, you come and chair one of our conferences. That would be a pleasure to have you there. Lastly, I would say that SOGP has shown tremendous progress in this COVID era. And I think that a very pertinent comment was made over here that we have reshifted our time into focusing more on educational activities which are of benefit not only to the trainees, but I think to all of us as well. And these opportunities of training of trainers, they should continue and they should be a part of our routine. And I was very happy to see you all, and thank you very much.
Thank you very much. Shall we conclude, Halima?
Yes, ma'am.
Thank you very much. Take
thank
care.
You, everyone. A sincere gratitude message from Society of Ops and Gynae. It was a pleasure to have you all with us today. Thank you again.
Thank you.